wanted to emphasize. And of course, I had not seen any of her slides before I actually put mine together. So it mirrors much of what she said. At VCU, I am the medical director of transfusion medicine, and part of my job is running the blood bank, and the other portion of my job is performing apheresis procedures. And it's very funny because people say, oh, pathologists don't have patient contact. So I will tell you, I see anywhere from 10 to 20 patients daily. My unit runs from 8 in the morning until 9 o'clock at night. We do stem cell collections. We do CAR T cell collection, which are then sent out for genetic engineering. I do plasmapheresis. I do red blood cell exchanges in sickle cell patients. And I do plasmapheresis. Most recently, my sister was diagnosed with myasthenia gravis, and she is now one of my patients that we actually perform plasmapheresis on. So this does many times hit home. So I feel like it's my job to really talk to my residents to get them to learn that this is another part of their job. They're not just sitting down looking at glass slides or grossing in tissues or looking at plates in microbiology or talking to laboratory professionals on the daily job. But the other part of their job is to actually sit and talk with patients. And one of the things that I say to them is, you know what, greet that patient like you would someone that you're just meeting for the first time on the street. They're no different. So sit down, introduce yourself, and make yourself comfortable. Ask them how they're feeling that day. Sometimes they don't feel well when they're coming for apheresis procedures. And then the other thing is, I always say, like Michelle already mentioned, what's your understanding of what's going to happen today? Because many times they may have been prefaced by another hematology oncologist or a bone marrow transplanter about what's going to happen with them today, or the nephrologist or the neurologist, depending on who's referring them to us. So what is your understanding of what's going to happen to you today? And then what is your understanding of the procedure that we're going to do? And then start filling in those gaps. But at least you have a place of where you're going to start with that patient. And then the other thing is that I always try to say to them, you know, I will hear them use words like anticoagulants, which a lot of patients don't understand. So I just try to say, speak to them like you would like a family member. Use the word blood thinners instead. People understand what a blood thinner is. They may not understand how it works, but they understand the principle of that. And then to use some understandable analogies. So one that I always talk to them about for stem cell collection when I do autologous stem cells for multiple myeloma is I describe the multiple myeloma cells as dandelions. And the chemo that we've used as basically, or that we're going to use after we've collected their stem cells, as Roundup. And just sort of explain to them that we're basically trying to kill all those dandelions. And many times we do a tandem stem cell transplant. And I just explain, you know, we kill the lawn and all the dandelions with the Roundup, and then we're going to do the stem cell transplant, give you back the stem cells, and then we're going to use Roundup again and go through that process again, trying to kill all of those deep-rooted dandelions that might be there, because that's very much how multiple myeloma cells are. That's something that they can understand. If I start talking very technical to them, you can just see that glazed over look, like, what is this woman talking to me about? So it's very important to use these kind of, and that's just one example of some of the analogies that I use for them. The other thing is that I was in private practice first when I first left residency. And yes, I was a general practice pathologist, but I also still took care of the blood banks there before I came back to the university. Blood banking was always my passion. And even though I was behind the scenes a lot of times signing out glass, I still felt a responsibility to go and meet with patients that were in our facility. We had one of the rarest blood types, and a person who had formed an antibody to who had a very rare blood type and formed an antibody to a very high frequency antigen. And I really felt it was a responsibility to go and talk to her and say, let me explain to you how rare your blood type is, and that if you need a transfusion, there will not be blood available in the city of Richmond for you. and try to encourage her to go and donate for herself, freeze the blood for herself so that it's available for her if she were to need it. I also encourage my patients, my residents, to go and talk to patients when they have transfusion reactions. There's so much to be gleaned from that patient's experience that a lot of times the nurse or the resident who is taking care of that patient may not have taken the time to ask them about. So I require them to go and meet with all of the patients who've had transfusion reactions. And then one of the things that I hate to have to address but have had to do on a couple of occasions are missed transfusions. And this is one of those events that we all hate to hear about, but it's really my responsibility. I always think it's important to talk to risk management, let them know what you're about to do. Do they have any pointers or any suggestions? And then I just go and sit at the bedside with that person. One of the most amazing events I had was a missed transfusion of a patient, and he was a mechanical engineer, and he was so glad that I came and talked to him, and he said, when I feel better, will you come and give me a tour of the blood bank? I said, I'm happy to give you a tour of the blood bank. It ends up that this gentleman had acute myelocytic leukemia. That was my first encounter with that missed transfusion. It could have been a disastrous event. It could have been an event of animosity and anger of the patient. But I followed up with him. I took him into the blood bank. I gave him a tour. He had acute myelocytic leukemia, and I knew what was going to be coming next. In order for him to survive, he was going to have to undergo an allogeneic stem cell transplant. So it was no surprise when I got to meet a sister that I collected for her stem cell transplant. Then we transplanted him. We actually collected her twice, so I got to meet his sister, Cindy, while we were doing collections over many days. And then he was transplanted and, of course, went through graft versus host disease. So guess what? He came back again to me for photopheresis. So this was a patient that I could have, again, if that first encounter had not been positive, if I had not taken the time for that, that could have been years of sort of this difficult, tenuous relationship. But it ended up being a wonderful relationship until the day he unfortunately lost his battle with acute myelocytic leukemia. So these are some of the examples that I have. This is another amazing man. This is Reed Whitener, one of my, again, patient that I kept seeing on multiple occasions. We collected Reed for 2 different autologous stem cell transplants to treat multiple myeloma. He failed both of the autologous stem cell transplants. We then went and collected his brother for an allogeneic stem cell transplant, which was successful. Unfortunately, he experienced grade 4 GI graft versus host disease. He is the only person that we've had at VCU that has survived a grade 4 GI graft versus host disease episode. We treated him for over 2 years with photopheresis. We were able to graduate him off of photopheresis. And then some years later, Reed came back to us again with FSGS, which was induced by the stem cell transplant that he developed, and he came back for plasmapheresis. So I've been treating Reed now for on and off for 10 years, and I just saw him at the Earth, Wind, and Fire concert last month. And I said, Reed, will you please take a picture with me? So anyway, so these are relationships, and so when I see medical students who I teach, I am the undergraduate medical education director, and they see me on the floor and they say, Dr. Sanford, what are you doing on the floor? I said, I'm treating patients just like anybody else here. So I think that it's something that a lot of times people forget, that pathologists, yes, I do have a very niche sort of practice, but even in private practice, you can expand that role and have a role with patients in your practice. Thank you.